Hi, everyone, and welcome to another episode of the Pain Consultants USA podcast. I'm Dr. Bonner here with Dr. Connor again, and today we're going to be discussing the Netflix docuseries, I guess you'd call it, The Pharmacist, which was a story about a pharmacist in the New Orleans area who had a lot of interesting things happen in his life, and some of it is kind of relevant to topics that we discuss and deal with regularly in our practice. So we wanted to talk about it a little bit and see if see what we thought and see what anybody else thought about it. So, Dr. Connor, how you doing today?
Good. Yourself?
I'm doing great, thank you. So, The Pharmacist was about 4 hours, I guess, 4 different episodes, and they were very different. It starts in one place and gets to a very different place, and then gets to kind of even a different place after that. Kind of starts with, I guess, for those who haven't watched, or if you have, this guy Dan Schneider, who's a pharmacist in the St. Bernard Parish in New Orleans, and the whole first episode is kind of about how his son was murdered and what seemed to be kind of a drug deal gone bad or something of the sort. And Mr. Schneider did not take the police's explanation of what happened, and he got into investigating it very intensely himself. I think that number one, the overriding thing you learn is Dan Schneider is a persistent guy. I mean, I don't think I've known many people that have the persistence of that guy.
He's great, though. I'd love to meet that guy.
I mean, maybe we'll have the pleasure of talking to him someday. I mean, look, that's a guy you want to have on your side. He takes rigorous notes. He recorded. It was amazing that he recorded everything. Like, he was just in a day where, this is in the mid to late 90s and then into the early 2000s, kind of in a day where cell phones were really just becoming very popular. The iPhone probably came out like 2007-ish. And so it's before the iPhone even exists, and he's got a old school tape recorder, and he's just recording every single thing that he does on the phone. He's sitting in his car just talking to himself. He's sitting at home talking to himself in the recorder, and it's pretty marvelous that he kept such good track of all this information and still has it all. And then to go through it all at this point, I mean, it must have taken endless hours to go through all, because I can't imagine all the stuff they have that wasn't used in the documentary,
Yeah. No, I mean, he kept meticulous notes and how everything was stored. It was a library. It was interesting.
Literally a library.
But no, I mean, I think anybody that isn't satisfied with an answer when they feel they or their family's been wronged, and the way he took it upon himself to get the answers. I mean, that was pretty cool.
Yeah, definitely. And, it's just a scenario where, we see this sometimes in our practices where you see a patient who you might not know what's going on, and there's probably is something going on, but, they've seen maybe a lot of different physicians, a lot of different therapists, a lot of different types of practitioners with no real answer for what they have. And sometimes they have someone like Mr. Schneider on their side who keeps looking and searching, and maybe they finally eventually find something. And other people, they don't have the persistence. They don't have someone with the persistence with them. And so I always tell patients, make sure you have good advocates for your care. You need people who are out there looking out for the best in you. And, that's kind of what he was doing. He didn't have answers, and he wanted answers. So,
I mean, that's a great point. I always tell patients anymore, you have to be your own best advocate. I don't, and I guess that could be a whole conversation. Well, why do we think that is nowadays? I would assume, some superficial thinking would be just the amount of time physicians have to spend with patients, is a lot less. There's a lot of other kind of burdensome paperwork and other things that are now involved. I've seen physician notes from 10 years ago, or it was just a couple scribbles on a piece of paper.
Right.
Now a note is 4 pages long.
Right. And
And
what's the reason for that? The legality and then
yeah,
the billing systems now, right?
billing.
So,
Yeah, I mean,
you know, you don't want to
I
get
would
sued.
obviously, yeah,
Right. Right.
but
I
it's
mean,
all
that's
comes
one of
down
the
to
things
billing.
that yeah. Yeah.
Your note is used for billing now.
Right, exactly. So the notes are excessive because they allow physicians to get reimbursed more for the work that they're doing. And it's not that they're not doing the work, but if you don't document it, then you can't get paid for it. So everyone has systems now to document it and make it simple to, or as simple as possible to do these things. But um, it still takes time and it still takes a lot of effort. And so maybe that is one of the reasons. Another reason is people are just really, some of these patients are really complicated and it's really hard to figure out what the problem is. So, or maybe there's like one patient or one physician in the country who treats this problem, this rare problem that they have or knows about it. So you just got to keep looking until you find the person who has seen a patient like you before and knows what to do.
Well, and that's probably another good point. I never thought of this, but like the subspecialization
Yeah.
in healthcare now, right? I mean,
Yeah.
there's compared to 20 years ago, right? We know a lot more,
Right.
but so it's impossible for one person to keep up with that. But you go to the wrong person or to someone that doesn't specialize in that. Well, it kind of gets pushed to the side, and then
Yeah.
you end up seeing 4 or 5 different providers, and
Yeah.
then everybody's got a little piece, but maybe it's hard to put the puzzle together because
Yeah.
it's all scattered about.
Yeah, I had a good kind of example of that. I had a friend whose young child might have been dealing with like some what could have been a neuromuscular issue, and they had seen a lot of people, pediatrician, pediatric orthopedic surgeon, pediatric neurologist, and I kind of discussed the case and said, look, you need to see a very specific person to really try to figure out if there is a problem here and what that problem is here. I don't know that person, but I could probably help point you in the direction. Or, for that problem, it's like a pediatric neuromuscular specialist, which is extremely subspecialized. But, they had gotten different answers leading up to that. And once they got to that doctor's kind of like, oh, yeah, I see these types of complaints all the time. This is what I see all day, right? Kids maybe not progressing as expected in sports in like young childhood. So what's going on here? That's probably something that they see all day. Whereas a lot of the other people, the orthopedic surgeon was looking for like a hip joint problem, and the neurologist was looking for like a neuropathy or something like that wasn't there. And so you need to keep persisting in these things. So it's just a good
Yeah.
lesson to follow that guy and just see, you really find him to be probably like the most annoying person ever by the end of it, but he got things done in the end. So you got to take a lesson from that, right? He got a lot of things done.
Yeah, listening to like some of the law enforcement version,
Yeah.
or how they took them.
Yeah.
But I don't know if I necessarily believe them. Like they were. Oh yeah, we were working on all this. I
Oh
don't know.
yeah.
I
Yeah.
I think I think you're just covering. He was
Yeah,
doing all the
totally.
work.
Yeah, they're like, no, totally. Don't worry about it, Mr. Schneider. Like, we're looking into it. We're taking care of it. And, that's probably just them reassuring him. And, they got so much else going on, they can't just
Yeah.
deal with one, I don't know. So I don't know if we said specifically, but his son was murdered and this drug deal gone bad. His son was a teenager, and his son was seeking out drugs in a bad area of New Orleans when he didn't even know his son was addicted to, or maybe he wasn't addicted, but was doing these hard drugs. And so it was kind of shocking in that aspect. And then how did his son get killed? He knew his son to be a good kid. He wasn't mixed up in things like that. And, and so it was kind of all a shock. And, for the cops, they probably see murders like that every day, every other day, you know? So I think in part of the documentary, they mentioned that, you know, New Orleans had a major crack cocaine problem in like in the 80s. So, you know, it was probably, you know, this was now more prescription pills and heroin, but this probably wasn't very, very different to them. They're used to this. They see it every day. Whereas Dan Schneider's probably never seen, you know, maybe never seen a dead body, you know? So,
Well,
so
I
it's
mean,
just, it's all
yeah,
relative, right?
yeah, you become numb to it a little bit. I guess
Yeah.
coming back to like, physicians where if they see the same thing over and over, and a patient might wonder why they might not seem as empathetic to them as maybe they should. It could be for that same reason, right? Like,
Yeah. Totally.
so, but then as episodes 2 through 4 really get into kind of the meat of moving forward into the whole opioid epidemic and the development of it, which was very interesting and probably educational for some people who don't know kind of how we got here.
Yeah. Yeah. And I've read a book or two about kind of how this happened too. And, you know, it's very interesting. There seems to be a lot of blame to go around. And a lot of that is still kind of panning out in the courts to this day with the pharmaceutical companies. Um, but I guess, do you want to talk about this specific story with them? Or, I mean, this is probably very early on. So they're probably, you know, as far as they knew, there wasn't really any doctors who had really been prosecuted for anything like a pill mill
Yeah.
at this time. You know, this is really early on in the late 90s, early 2000s.
Yeah, I
Um,
mean, I guess like a little synopsis, like even before that, right? And
yeah,
the series touches on it briefly, but in the 80s, right? Opioids weren't really used to treat chronic pain. They for that wasn't associated with cancer. But
right.
then, transitioning into the 90s, and then obviously into the early 2000s, there became a big push by a couple different groups. First, right, there was pharmaceutical industry, especially Purdue Pharma, right? I mean, everybody knows that if you kind of Google that. We're not just picking on them, but they've put out a lot of educational material uh, about the safety of opioids, even though we know they weren't safe, right? There was at least two big opioid epidemics decades before, so we knew of the destruction that these medicines could cause. But so you have the drug company on one end, you have Joint Commission, right? There's federal agencies that really kind of pushed the narrative about pain being the fifth vital sign. Um, Depending who you listen to or who you read, some of the stats about chronic pain became inflated as well. Um, right? So the definition is 3 to 6 months of living with pain. And I mean, I'm guilty of this too. I've quoted some of those numbers, but you think about it, right? Lumbar disc herniation. I easily tell patients it could take 6 months or longer for it to get better, right?
Yep.
So should we call that chronic pain, or should we get more specific about, well, what's causing the pain, and then we we give
Change.
give it a timeline for
Yeah.
that standpoint,
Right. Yeah.
But either way, the numbers grew astronomically. Once it became a fifth vital sign, the way doctors were reimbursed became linked to patient satisfaction, which was another big issue. And then just bad doctors, right? They
Right.
Doctors who are just bad apples. They unfortunately saw a disgusting opportunity to make a lot of money on people's addiction, and they started opening up these clinics that eventually got turned pill mills, and cash for pills. I mean, they were just drug dealing in a white coat.
Yeah. So let's go back to the pain as the fifth vital sign thing. So, you know, the first off, You know, if you're a patient, you're listening, you're wondering kind of why is that brought up? What's the problem there? Well, what are the other vital signs? The other vital signs are like your pulse and your blood pressure and your temperature. These are very objective measures. So these are things where I put a blood pressure cuff on your arm, I take a reading, and we know what your blood pressure is. I check your pulse. Okay. I counted it up. I know that your pulse is 65. I can't do that for your pain. There's no meter I can put on you. There's nothing I can like. I can't take a temperature gun, stick it under your tongue, and say, "Oh, your pain is a 6 out of 10 right now." Okay, I should help you with that. You know, the pain level is very subjective. So, and we know that people experience pain very, very differently. So there's the whole spectrum. There's people who are unable to really sense pain, and there's people who sense too much pain for what they're really feeling, or we've talked about before, kind of these abnormal sensations of pain for things that shouldn't be painful. Like if I just touch your skin and you feel pain, that's something called allodynia, where it's a painful response to something that shouldn't be painful. So there's all different kind of levels of pain response. And so we need to take that into account when we're evaluating a patient who has pain. And we can't just say pain is a vital sign. We don't have an objective measure of it. So that's really the important thing there is, although we need to rely on our patients, we need to kind of do that in a kind of comprehensive evaluation. I don't need a comprehensive evaluation to find out what your pulse is. I know what your pulse is when I take your pulse. I know what your blood pressure is when I take your blood pressure. If you tell me your pain's a 5 out of 10, then I follow up with questions, well, can you go to the bathroom without pain? Can you clean the house without pain? Can you exercise without pain? For some person, that might be yes, I can. And another person might be no, and they might both tell you they have a 5. And so we can see that pain is kind of affecting people differently. And then that's how we need to kind of take it into account with many other things as well. But that's just kind of a basic idea of how that's different.
Yeah, and one, I think a big component of that and how pain is interpreted, which has never really been given, it's probably it's due. Now it's starting to become more prominent, is how pain affects your mood, right? Depression, anxiety related to the pain. These are also things that are very difficult to measure objectively. We have some scales and things like that, but we know it doesn't mean pain's in your head, but it means if the pain is kind of caused you to be depressed or feeling down because you're not able to do as much, well, once you start feeling that way, your pain's going to be worse too. So I think a lot of the times, we as a medical kind of community have always just gone right to pills for treating things that are a little more complex. Pills can't fix everything.
Yeah, that's definitely true. And the other thing I wanted to go back to was, you were discussing how some of the pharmaceutical companies were saying, oh, well, these medications aren't really addictive, and we already knew. And, what we go back to, everything that I've read goes back to kind of, there wasn't even really a study. There was more an observation and a letter written saying that, 200 something patients were treated as inpatients in the hospital with these opioids, and none of them showed any signs of addiction. And then Purdue in particular utilized that letter to the editor as a sign that, oh, well, this medication is not addictive, or it's less addictive than previous opioids. And that just really wasn't a proper study. It wasn't even meant to be a proper study. It wasn't meant to be interpreted that way. It wasn't patients who were not in the hospital with chronic pain. It was patients that were in the hospital with pain and then were discharged from the hospital, and they weren't followed after the hospital. It's just while they were in the hospital. So it was a very different scenario than what was being encouraged for physicians to do, which was prescribe these medications for patients who had chronic pain issues. And so the information being given to physicians saying, hey, look, we did this, this study was done, and it's not addictive. Oh, well, I'm sure that sounded great to physicians at the time. Like, oh, great. Like, you've found a way you found the golden goose, really. You found this pill that treats pain and people don't get addicted to it. But it just wasn't true. I mean,
Now,
it's just blatantly wasn't true at this point.
let me ask you this, because it's always easy to play kind of Monday morning quarterback, but right, because
Yeah.
we when all of this kind of first began, right now we're dealing with the consequences of it, but when it really kind of the seeds were planted, can you, as a physician, do you really buy that? Like, how did most physicians just say okay to that? Like,
I think there was probably a spectrum of responses, right? Probably people who were like, no way, I don't believe it. Let me look at it and see, and looked at the actual paper and saw right away that it was bogus. There's probably people that are in the middle. Okay, sounds pretty good. Let me try it, see what happens. Started with low doses, found some benefits, but found some addiction, and quickly kind of realized that they weren't being fed the right information. There was probably people that were like, "Oh, this is great. Let me get everyone on this. This is fantastic." Got everyone on it, realized that there is serious addiction problems, and then there was probably people like the doctor and the pharmacist, Dr. Cleggett, who it didn't really seem to matter to. She was just giving it out willy nilly. I think in the last episode they said when they raided the office, they just found boxes full of pre-written prescriptions for OxyContin, and they were just waiting for a patient's name to be put on them and a date to be put on them. So, I think there's probably a whole spectrum of responses, but I think you probably most of them were on kind of skewed towards, okay, let me test this out and see what happens, and then
yeah,
probably realize that there's some issue. But it doesn't, it's always a reminder for us to remember to double check things. You can't just believe. There's always people coming to us. Hey, use my product. Hey, use our medication. Hey, use this, use that. We got to double check things for ourselves. Just because they say it's true doesn't mean it's true. Just because there's a study doesn't mean that they didn't pay for that study. And since they paid for it, they may have paid for 5 others that aren't published that didn't show a good result, but they published the one that had the good result so that people will use it. So, we always have to kind of weigh these things, and it's difficult, definitely.
yeah, no, I mean, there's a bias towards all that.
Yeah.
I was just thinking as we're talking, I wonder too if, as more got out there about chronic pain, right? I mean, almost like a marketing ploy for patients or individuals themselves to kind of put a name to what they might have been experiencing for years and just were okay with it till then, right? I mean,
Right.
oh, I have aches and pains. Well, I'm going through life. I mean, that's going to happen.
Yeah.
Probably did some crazy things when I was younger, and now I have some aches and pains, but all of a sudden, oh, there's a name to it, chronic pain or chronic pain syndrome. And now there's a medicine being marketed for that. It was a perfect storm.
Yeah, it really was. It was a perfect storm, definitely. All the right things came together at the right time for the use of OxyContin specifically to just balloon out of control. And
Yeah.
and that was part of the consequence. So the story kind of in the series moves from the murder of Mr. Schneider's son to he goes back to working in a pharmacy, and he sees lots of younger people coming in with high dose OxyContin prescriptions and starts wondering what's happening. He looks, and it's mostly coming from the same doctor who we mentioned already, this Dr. Cleggett, who was there. And so he starts looking into Dr. Cleggett because he doesn't understand why so many young patients are being placed on such high dose opioids like OxyContin. And and the first most glaring thing is that Dr. Cleggett is a pediatrician by training. So what is Dr. Cleggett doing? Prescribing high dose of OxyContin for adults. It doesn't seem to fit. I don't know. I don't know what you thought, but that was definitely a
And
laughing moment for me.
and and I think that goes back to the timing and the era it was in, right? I
Yeah.
mean, I couldn't imagine that flying nowadays
Yeah.
with
No.
how much kind of regulation, restrictions, and kind of just monitoring that is done through the system. Like, I mean, even though it's kind of a little bit of a burden on physicians who do continue to prescribe some of these medicines, right? There's checks and balances now with insurance companies, pharmacies, and none of that really existed before. So
Right.
again, yeah, perfect storm. I mean, that couldn't happen today, or I would
Right.
like to think it couldn't.
Right. Right. So, other red flags that I wrote down, some of the patients were waiting up to 2 days at the office. uh, and the clinic was open at 2 a.m. I mean, I have to say, I have heard of a couple clinics here in Miami, one for a neurosurgeon where the patients will be there till midnight or 1 a.m. And it's not, there's no prescription of pain meds going on there. I guess it's just he probably spends all day in the operating room and then goes to clinic after the operating room. And so he's at clinic. I've heard people getting picked up at 2 a.m. in the morning at this clinic after being seen. So,
Yeah.
but, that's a red flag for an outpatient clinic that's open at 2 a.m., especially when, as an outpatient clinic, they're accepting cash only and then also accepting extra cash to move up in the line to be seen before the other people. So that was an interesting tidbit. Also, I mean, that's pretty
I,
funny.
and I mean, with all of this, right? All the everything we've just kind of covered, what it did was it flooded the system with pain pills, right?
Right.
There was so high quantity prescribed, not only the dose but the number of pills, right? So some of these patients were getting a couple hundred pills a month,
Yeah.
and you know, so obviously that puts the person who's using these at risk, but then a lot of them were selling it, right? I think they talked about this. A lot of patients had enough to sell, make quite a bit of money. I think we all heard the stories that, at one point or another, when you buy these on the street, it would be $1 per milligram, right?
Hmm.
So 80
Hmm.
milligram pill would be $80 kind of thing.
Yeah.
But and this is my own opinion, but I think what would have happened too is, it's hard to see a few missing, like at home. If you do have the prescription at home, it's hard to see a few missing if you have 100 or 200 pills and your kid was interested in
Right.
seeing, well, what do these do, right? So,
Right. Right.
and then it got a whole other population addicted, right?
Yeah.
These pills, I mean, they're potent. It can only take one time for people who are at risk for substance abuse development to really become hooked,
Yeah.
especially young kids and people who have family history. I mean, they're some of the higher risk patients who, okay, well, instead of being curious about your parents' alcohol, all these pills were around. I think kids became curious about these pills, and then, um, then it kind of morphed into a whole other kind of generational issue.
Yeah. Definitely. Definitely. And you're talking about how it created a whole other problem. Uh, I thought this talked a lot about similar things to a book I read a while back that was called Dreamland, I think by Sam Quinones. And it was just like it weaved kind of this story of the OxyContin production and marketing in with the heroin epidemic. particularly from Mexico, because the Mexicans were able to produce very cheap heroin. So they produce different type of heroin, I guess, compared to the classic kind of, I guess, what would be called like Middle Eastern that came from like Afghanistan or yeah, I think mostly Afghanistan, but they produce in Mexico a black tar heroin, and it's cheaply produced and potent, and so they could sell it for cheap. And so the classic story was that someone would get hooked on the pill when they couldn't afford the pill anymore or couldn't get it from the doctor. They'd go to the heroin, which was cheaper. And then the problem with the heroin is they can't track really how strong it is, so they may think that they're getting the same strength they had last week when it's really twice as strong, and they overdose. And then the overdoses just became really out of control, a lot because of that reason. Another thing I remember from the book that you're talking about selling these pills for like $1 a milligram. They discuss a town in Ohio that was like particularly hard hit by the opioid epidemic, and they said really OxyContin became the currency in the town. Like people weren't paying money for things; people were paying for OxyContin with goods. So there was like one family who controlled all the OxyContin, and they'd be like, "Hey, we have a new baby. We need diapers. Bring us some diapers, and I'll give you a few pills." And people would go steal diapers from the store down the street, bring them diapers, and then they give them pills. And then they said that everyone was stealing from like the Walmart or something to then go to this one house and get OxyContin from them. So the one store was providing all of the goods that were being stolen to then be traded for OxyContin. They said it basically became the currency of the town, which, it's hard to imagine, but it's happening, or it happened. I don't know that it's still happening anywhere, but it definitely happened. Hopefully it's under much better control, but I mean, there's still significant amounts of opioid overdose deaths. And, at the end of the documentary, they said that there had been more than 400,000 opioid related deaths since, some time period, some like kind of 15-year time period, maybe like 2000 to 2015 or 2000 to 2017. But that's a lot of deaths. And just hearing these stories, it makes you realize how bad it is somewhere. I certainly wasn't exposed to it where I grew up, but you hear about places like this, and those places really exist. And a doctor like this giving out the pills to anyone who comes in is what can really kind of make it much, much worse. If there's not that situation, maybe less people get their hands on it and are less interested in the pills and less interested in heroin. But a doctor like this really can make it much, much worse, seemingly.
Yeah, and I think underlying all this is, we always talk about the opioid epidemic, but America has always had, in one kind of, I guess, in the shadows, right, a substance abuse issue, right? There's always been waves of different drugs that were more predominant at different times throughout our history. Whether it's, like you mentioned, the cocaine or this was the opioid. And I think it probably affected even more people because it's a neat little pill, right? That you get from a doctor, instead of having to get stuff off the street. Now, it changed as the 2000s went on, and you get into probably 2010 and onward, where okay, now we're starting to realize there's an issue. It took forever. Again, Dan was probably a decade before most when realizing this. But then you get into like the 2015. Okay, now they start cracking down. That's when everybody flips over to heroin. And then more recently, you get from like you were talking about Mexico, but then China with the synthetic fentanyl. Right. It's interesting, the area that one of the areas that I've attended some meetings on the opioid epidemic within smaller communities, and what they've seen is opioid overdose deaths, whether prescription or, heroin or fentanyl, have been going down. And then what's rising now is methamphetamine
Mm.
again. So
Mm.
it's right. There's people are addicted, and then it's a matter of what they can get their hands on. And
Yeah. Yeah.
there's a,
Interesting.
yeah, that goes.
Huh. Some other things that they talked about. They did have that guy who's a rep for Purdue Pharmaceuticals. And I thought,
What'd you think of him? He was interesting. I
yeah, he
mean,
was interesting. I mean, I think, I mean, it was good to hear. Of course, anyone that they had on there would probably be like him, where they said, at some point he quit. He said it was too much. But, he did mention, I thought it was really interesting how he mentioned that one rep was making apparently $800,000 per year because of how many Oxycontin pills were being distributed in that one area of New Orleans. I mean, I don't know how much a typical representative would make for a pharmaceutical company, but that is just an insane amount of money. I mean, that's I mean, the average pharmaceutical rep can't be making $100,000 per year, let alone even close to $800,000 per year. That's wildly high. And so that that was just another thing that it makes you think about how many pills were really being distributed, because it must be so many for that person to get it. They're just getting a bonus based on what's being prescribed. you know that's not even on top of how much money the pharmaceutical company is making from the pill too. So, and that's just in one area. That person was like a regional representative for some area in New Orleans there.
yeah. I mean, uh, can't say much more than that. Eight
I
hundred
know.
thousand dollars. I mean,
That was crazy. And then there was a story about a father who injected his own son with Oxycontin and the son died. I just thought that was terrible. It just some of these families get so desperate. If you ever watch that show like Intervention back in the day, it may still be on, I don't even know, but it just the desperation that occurs. If two people, and maybe the father and the son are both addicted and the mother is not, and she's probably just in the worst situation ever. But I mean, addiction is terrible, as we all know, but some of these stories were just kind of crazy. And then how the pharmacist had, like, he said he had a death list. He said there's people he was like waiting for them to die of overdoses because they were just on such high doses, and he would cross off the list as like he read the obituaries. And it's just like, it's crazy. He was predicting kind of what was going to happen. And you know I don't know, it's unbelievable it went on for so long. Throughout the thing, he's talking about how no one's responding to him and no one's doing anything and no one's doing anything. And they say they don't have enough, they need more, well, I don't it's hard to see how they would need more. I know it's always complicated in legal matters, but it's hard to see how you would need more than some of these things where you know she's a pediatrician treating chronic pain, number one. I mean,
yeah,
in adults, that just doesn't even make sense. And then there's so much more on top of that. I don't know.
yeah, yeah. I mean, I think it just goes back to, it was a different time. Like we could never imagine
Yeah.
that now. What I
Yeah.
found interesting was the way they finally shut down the practice was getting the medical board involved
Right.
bef- before even the DEA or FBI or anyone did
Yeah.
anything.
Yeah.
So that was interesting.
Yeah. That was interesting. I was wondering, have you ever filed a complaint to the medical board?
No, but I know they're taken very seriously, and
Right.
I mean anybody could file a complaint to the medical
Right.
board, and then
Yeah.
an investigation is started. Um, uh, you know, I mean, it could be a complaint about anything, really.
Right.
Um,
Yeah.
but it's always kind of followed through. But yeah, that's interesting.
That was interesting. And it took him a long time to find out the information that was really the route to go. you know.
We found I think, was it a lawyer in Ohio or somewhere?
Yeah, it was when the doctor in Ohio was prosecuted and arrested and
Uh,
prosecuted for the similar thing. He was like, "Wait, how did they make this happen?" And he called I forget if it was a district attorney or whatnot, but said, "Hey, how did you get this done?" And said, "Well, actually, the state medical board is what really made it happen." You know,
yeah.
and that's true. It's probably hard for the DEA to evaluate the appropriateness of medical care, whereas that's what the state medical board should be for. Um, so that was very interesting.
Yeah, now with each state having the PDMP, which is, I'm sure if you've heard doctors have to sign in before they prescribe a controlled substance, make sure patients haven't been getting them from somewhere else. So that really cut down on doctor shopping.
Yeah.
But then that also made it a lot easier for law enforcement. And I know at least in Pennsylvania, I think it's nationwide, they don't need a warrant to look at the PDMP.
Mm,
So they can just go on, and
right.
if they have a patient's name or a person's name of interest, they could see any controlled substances prescribed by whatever physician.
Yeah, the one DEA agent mentioned that towards the end of the whole thing, saying that it's much easier now. And um, you know, Dan Schneider was one of the people who was a big proponent of that. I guess in New Orleans, he sent a letter to, I think, someone in the state saying, "Hey, we need to look into doing this. Other states are doing this. We should do this." And they were like, "This is a great idea," and they did it in response to him. It was another one of those things where you're like, "Oh my God, here he goes again," and he got something done again, you know. But it really is. It's very useful, you know. It makes it very easy. We just log in there, you put in the patient's information, and we can see the patient's, you can see the different addresses the patient has or has had in the past, and you can see all controlled substances, which are mostly kind of opioids, and then benzodiazepines, and Lyrica goes on there, and like testosterone goes on
Yeah.
there.
Adderall type.
Adderall, yeah. Yeah, so you can kind of see what's been going on in terms of those controlled substances, and just evaluate for any anomalies, any kind of unusual behaviors that might have been there, or extra medications that you weren't aware of. And so it's just a very helpful resource for us to have. So, we've kind of come up in a world that's already experienced a lot of these problems and then responded and made solutions for them. So we've had it quite a bit easier because of things like that, I would say.
Yeah. You wonder how many lives Dan Schneider really did save
Yeah.
with. It's pretty cool to think about.
Yeah, I mean, just
Yeah.
shutting down an office like that where
Yeah.
everyone's getting these pills. I mean, but then he also said, when he shut down the office, what happened was the heroin deaths skyrocketed. And he was
Hmm.
like, "Oh my God, did I create a new problem?" You
Yeah.
know? So, but then he did something about that. He was going to schools and talking about it and things like that. So, um, as long, his intentions were always good, which is good to see. He was always trying to do the best for other people. And, maybe there was a bad consequence of, he was really trying to do the best by shutting down that office. Maybe there was a bad consequence of it, but in general, the idea was good.
Yeah.
So
Yeah.
what did you think of Dr. Cleggett when they brought her on?
I mean, at least what they had described. I mean, she sounds like she was an addict, right? She had her own substance abuse issues, and physicians aren't exempt to that either. But I mean, she's just not a good human being.
Yeah.
It's like she's still claiming she didn't do much wrong, and I was shocked. She got like no jail. She got no jail time.
Yeah, well, she had that really bad accident, and then they like seemed to,
It's
I
crazy.
guess,
I don't
give her
know.
some
Yeah,
reprieve based on that. But yeah, that was
it
tough. I mean,
it seemed
the
like they were
DEA
just
agent
content.
wasn't happy with that.
It just seemed like they were content, kind of making sure she didn't practice medicine again. I
Right.
feel like she was lucky. I mean, she should have been arrested.
Yeah, she was lucky in one sense, but that, I mean, who knows what happened with that accident, but she looked like she was still definitely dealing with the effects and will be for the rest of her life, related to
Well,
that, whatever that was, totally unrelated to everything else.
that's called karma.
Yeah, yeah, maybe, right? I just, I felt like her initial response right away was just like such a lawyerly response to like, what would you say if you were doing what she did, and and you had to defend yourself? Well, pain is a subjective experience, and OxyContin was very effective, and I was giving patients treatment for pain that was very effective in helping them. Well, you know what? That's not what you were doing, and that's not it at all. You know, like the last case that really threw him over the top is like a 16-year-old girl, and she prescribes OxyContin 80 milligrams, 1 or 2 tablets every 12 hours. Like that would have knocked that girl into a coma like right away.
Yeah.
It's just like that's totally irresponsible. So like
Yeah.
trying to say that is just anyone who knows anything about prescribing pain medications knows like right there that that's just not, you can't, that's not true, and you're trying to defend yourself, which of course you have to do, but it's just not
Yeah.
even close to true.
And just on the OxyContin thing for a second, where I did my fellowship, we spent time with like the psychologists and psychiatrists in the um, one of the addiction treatment centers, and talking to individuals who now have been able to get through the addiction and are now undergoing treatment and leading productive lives. They would all say the same thing: the OxyContin, right? Now the big thing about that, or the push for it, was it was an abuse deterrent, right? Formulation where it couldn't be abused. Well, that wasn't the case, and the higher the dose of OxyContin, the easier it was to actually abuse it. Like I heard a lot of people give firsthand
Interesting.
accounts about how they would, the 60s, 80s, it'd be easy to shave down pieces, and it was just the lower milligram content, the abuse deterrent seemed to maybe work a little better, but
Interesting.
the higher milligram ones, they were easily abused.
The other thing I remember, maybe from that book that I was talking about or from something else, was that the OxyContin, they said it was Q12 hour dosing, but it really should have been Q8 hour. And so what happened was patients were always having more pain toward the end. And so the dose was always being increased. And that was something that was seemingly kind of intentionally done to encourage higher dosages and encourage more usage of the medication. I don't know if you heard that or remember that being the case, but
Yeah, and I think that highlights a couple things too. Just, I mean, people who aren't experienced with managing pain too. I mean, I think shouldn't maybe be prescribing those medicines, or shouldn't have been
right,
back in the day. And again, probably most came from a good place, wanting to help their patients. But I would agree, right? So a lot of times, and you hear of opioid-induced hyperalgesia, which I think we've talked about before, but pain gets, you mistake worsening pain for maybe even like, the medicine's causing more pain, or they're actually going through little withdrawal symptoms in between
right,
doses.
yeah,
I've had, and I've heard that a lot with patients who are on like OxyContin and extended release oxycodone,
uh-huh.
um, where they would always same thing, like it would be always kind of in between dosing, even at 8 hours. Like a lot of people, they would just kind of feel a little jittery, feel like it wasn't working good enough, and yeah, I mean, then they feel good again once they take their next pill.
Yeah, of course.
I don't know if maybe I'm jumping ahead, but I'd be curious to just kind of get your input or your opinion on kind of where chronic pain and the use of opioids will be in the next 10 years.
um I think My experience in Florida is that Florida is getting pretty strict about the prescription of opioids, and so less and less physicians are willing to prescribe. I've seen a lot of pain doctors in the area just refuse to prescribe anymore. They say they're not going to do it anymore because it's too dangerous and it's too much of a hassle for them. So, seemingly it's going to probably continue to get less and less. That's only over the last few years. So I can imagine it's probably going to keep getting stricter. States where it's not that strict, it will get stricter. And then, at what point does it bounce back in the other direction would be the question. I don't know. I don't
Yeah.
think it's yet. I don't think it's yet, but maybe it's 10 years down the line, right? If this all kind of started mid to late 90s, give it 25 to 30 years to bounce back in the other direction. I don't, because
Yeah.
like you said, like we had opioid problems before. It's like we pretended they didn't exist.
Yeah.
And so we'll get to a point where we forget about Purdue Pharmaceutical. Granted, they're still in the news now, so they're dealing with all kinds of lawsuits from patients and states and counties and all these things. So once they kind of fade away, give it 10 years, everyone will forget about it. And who
Yeah.
knows what pharmaceutical company comes next and says they have the new pain medication.
Yeah. I mean, what was the timeline? I forget now. Like when it kind of ended the documentary. Was
I
it
think it was
like
2017.
was it that
Yeah.
far? But I
Yeah.
mean, like with because I know some of the stats they had given, like during I think Dr. Kleigert's heyday.
Oh,
When was she
oh,
done?
that was like 2005 maybe, or
Okay.
even earlier.
Yeah.
Even
Because
earlier maybe.
even though how crazy it was then, I think what they were saying they had maybe 15 or 2,000 deaths per year
Yeah.
down like in Louisiana
Yeah.
or something like that. I mean, I think it's I don't know the exact number off the top of my head, but even Pennsylvania 2 years ago, the deaths were upwards of close to like 5,000 still. You know what I
Yeah, I
mean? Like
think deaths
this isn't
surpassed like car accident deaths from
mhm,
opioids or
yeah,
something like a couple of years, like three, four
this
years ago. So
this is still going to be around for a long time. Um, I manage a lot of patients with chronic pain, and the area I'm in, there's been a big push for a lot of primary care physicians who have patients on opioids and who they prescribed to in the past, not to prescribe anymore. So they're really patients don't have too many options with regards to where they can go for those types of meds. But my own opinion is, and I think in 10 years, if you have a certain condition, I mean, you're not going to be able to get pain medicines, right? That's just not going to be in the treatment algorithm, right?
right.
Be
Yeah.
used
It's
for
just gonna
acute
get
pain.
stricter, right? Yeah.
Yeah, yeah. And I
Yeah.
don't necessarily think that's a bad thing,
Yeah.
but it's interesting, like when, just from a policy standpoint, like when does that occur? Or can you put a blanket statement out? Okay, for this condition, you get this many weeks of it if needed post surgery. For this, it's absolutely off the table, you know?
Yeah, I mean that probably depends a lot on the politicians. If some politician has a kid who dies of a heroin overdose, you're probably going to see a lot more legislation like that. Whereas, I who knows, politicians all have their reasons to focus on certain issues, and
Yeah.
it would probably take something that severe to really, really make it such an aggressive change. I think doctors are still going to have the chance to kind of make the decision whether or not it's really, really appropriate for a while. But there certainly could be a change. I wanted to bring up one other thing about Purdue and how they how they wanted to. I mean, the irony
Mhm.
of all irony. After saying that the medication wasn't addictive for years, they then wanted to get into addiction treatment
Mhm.
because of how many people were getting addicted. And then they were saying that, well, pain medication goes hand in hand with addiction. It was like, we just spent years just telling us that this
Yeah.
wasn't addictive. So what just happened? And now
Yeah.
you're going to like double up on your business because everyone's addicted and they all got to get unaddicted.
Yeah.
And we know that, trying to treat addiction isn't a one-time thing. I don't know what the average number of times someone goes to rehab before they finally stop using, and it's probably different for different substances, but it's not one time you go to rehab and you stop using. It's a handful of times at least.
Yeah, I mean, and some people struggle with it for their entire life. And some of these medicines that are now used, like these medication-assisted treatment um, programs, some people are on those medicines for the rest of their life,
Right.
right? So it's, yeah,
Right.
I mean, dirty, real dirty.
And they're also in a lawsuit. They just got like unveiled in a lawsuit recently that they were paying kickbacks to an electronic medical record system to get them to kind of promote the use of their medication. So it was like $150 million.
Wow.
So it was just like they were an unnamed pharmaceutical company for a while, but it was just like unveiled in the last few months that it was actually them that did that as well. So
Wow.
so they are, they're in hot water right now, and we'll see. I think their lawsuits are going to be going on for, well, I guess they're talking about a settlement, and it looked like, I was just doing a little reading. It looked like a lot of the discussion now is how much money did the family that owned Purdue Pharmaceutical, the Sackler family, really get out of the company. And so there's different people that have estimated that from a few billion up to like $13 billion. It's not really clear. They're trying to kind of add up all the different transfers of money to different bank accounts that are offshore and things. And I think a lot of the lawyers for all these states and counties are basically trying to say, look, you guys created this problem. You need to pay for the fixing
Yeah.
of it. And so,
Yeah, I know Pennsylvania was included with four other states. I think this past October they settled with like Purdue and like McKesson and a couple other like larger kind of middlemen manufacturers or dispensaries for like a huge lawsuit, and like half of the money, forget how many, it was maybe a couple $100 million was going towards substance abuse treatment programs, and the other half kind of for compensation, I think. So
yeah, yeah,
there's going to be a lot of that.
for sure. It's going to go on for a little while, probably.
Yeah, even though we're starting to see the downtrend in debts, like we said, it's going to be a good decade or so.
Yeah. What else did you want to talk about? Anything from that?
No, I think that was it. I mean, I know we've talked about it, but I'm still always shocked. Like, we live in a world where we always talk about this evidence-based medicine. And again, this just goes back to I still don't know how this exactly occurred, where all of this happened with absolutely no evidence
Right.
to support opioid use beyond
Right.
12 weeks, right?
Right.
There's no studies out there
Right.
beyond 12 weeks that
Right.
opioids. So it's crazy.
Well,
But
hopefully we can help prevent it from happening again. I think if you're a patient and you take one of these medications and you're considering changing to another medication or getting off of the medication and you have questions, please, feel free to email us or schedule an appointment. We are at this time kind of joining with other people in healthcare right now to kind of ease the burden of the issue with the coronavirus. We're offering all visits for a $50 flat rate. So, feel free to schedule an appointment. We'll be doing this at least for the foreseeable future until kind of we can get back to kind of normal life and get out of our own homes and go back to public spaces. But so, check us out on our website, and feel free to reach out to us if you have questions. All right. Thanks, Dr. Connor.
Have a good one, buddy.
All right.